Hey, everyone. Give a couple minutes. Hey, Dolores, Tom, Judy.
Good morning.
Good morning. Katie, Brandon.
Good morning.
Good morning.
Good morning, everyone.
Good morning. How's it look, Robbie?
Good. I think we can go ahead and get started, Timmy, and I'll keep admitting folks as they come in.
Okay, wonderful. Well, I know we have a really great agenda lined up today, and I just want to take a moment to congratulate our graduates that are out there. I had a high school graduate last week, and I know it's a very busy time for all of us. So if you have a graduate, high school, college, just really going through those activities and festivities this year is really a mark of 3 years that our youth have gone through a lot. So I'm very thankful that we have caring adults out there for our youth, and we're ready for the next phase. I think that's just my own wanting to kind of personalize today. But welcome to Connecting for Better Health. And if you are new with us or have been with us for a while, please use the chat to introduce yourselves. It's a great way to network, and I think there are many connections being made with these discussions, so we want to keep that up. Today we have Cloudticity joining us with Amber and Jerry. They will be walking through a use case that we discovered that was brought to us by one of our participants, Mary Sarah at AWS, that really was really compelling. And we wanted to share it all with you on how they helped New York Public Health respond to COVID. And so we're really looking forward to that. We also have Karen with us again from Intrepid Ascent to walk through the data sharing agreement fact finder that was just recently released by the California Healthcare Foundation. FYI, they have, I think, a four-part series, Karen, so we can make sure that we get that into your inbox as well. And finally, we'll just kind of wrap up and summarize the letter that we've submitted to the Data Sharing Framework Committee Advisory Group and the state around digital identities. And thank you all in advance for your support in getting that out the door in a very, very short time frame. And I think we should all be proud of that work. So with the next, I just start every meeting with our vision, purpose, and policy priorities. Our vision is that we have connected health across California, and that our caregivers and providers have the data that they need in order to care for the patients. And also we are able to, really better our decision-making on where to be able to put resources to have an equitable care throughout California. Our policy priorities have remained this year in 2022. We'll be re-looking at these for 2023, but we've been very focused on securing funding. And I think we have an update today on all that work that we've been doing. We did not see it in the governor's budget, but that doesn't mean that we stop working on that. And then also really focused on bringing the state along with us to have them understand across the state, different departments, the value of HIE and how they should be thinking about HIE as an asset, a state asset. And then if we go to the next slide too, we are bringing you programming. This is what Robbie and I do, and with help from all of you to be able to bring speakers like Cloudticity today, is to focus on the priority use cases of public health, and also the work that we're doing with bringing social services for our Medi-Cal transformation. And then, of course, being able to really kind of dive deep on those common elements that cross all of the HIE priority use cases. And that's where we are spending our time on developing fact sheets and bringing that education to you. So with that, I'm going to hand it over to Amber and Jerry to walk us through their work. And I think we have about 10, 15 minutes, 20 minutes set aside for this. We do have our other speakers as well as other content. And I do want to open it up to questions. Amber, I think you want to have this be interactive, so please use the chat for questions as we go forward. And Amber, I'll try to help jump in to help facilitate.
Perfect, thank you. And can you all see my screen okay, hear me okay? We're all good there, wonderful. And just fair warning, this is my favorite thing in the world to talk about. So Timmy, if you have any of that Oscar award show shut up music at any time you want to play, feel free to. But thank you all, everyone, for giving us the opportunity to meet you all and share some stories around how we collaborate with our customers. My name is Amber Glauser. I am a registered nurse by trade. I know that's always a head scratcher for everyone. Why in the world is a nurse working in cloud tech? And it really was born out of my frustration, a feeling that technology wasn't serving patients or clinicians. And so really, I'm on a personal life mission to make that better. And luckily, I found my place with a like-minded team at Cloudticity. And I'll share a little bit more about what we do in just a moment. But I'd also like to introduce our CEO and founder, Jerry Miller.
Hi, everyone. Jerry Miller, founder and CEO at Cloudticity. Thanks for having us here.
Yeah, so today, I know Timmy mentioned to everyone that we want to chat about the COVID-19 use case with the New York Department of Health, but actually I'd like to start a little bit broader and share some other work that we've done with other customers as well. So I'm going to dive in, kind of run through with you all the 1,000-foot view of what in the world is Cloudticity, then also some of the work that we've done in the health information exchange world and how we partner with organizations, and then ultimately how that, of course, supports the use cases within public health. So as Timmy mentioned, feel free, be interactive, ask questions. We're happy to answer anything that you might want to learn more about. All right, so just in starting off, helping you all understand who is Cloudticity. We were founded in 2011, and we focus exclusively on helping healthcare companies to be successful in the cloud. That's the simplest way to understand it. We have a lot of distinguishing characteristics and doing some of the first work in the cloud, specifically again with healthcare. I gave a couple of our customer names here too. Of course, we have a robust set of customers, but everyone in healthcare is the common thread. So we're very familiar with all of the challenges of serving different types of health tech needs. And of course, as we're going to talk today, focusing on the public health improvement itself as well. But just to let you all know, again, we're going to dive in a little bit on some of these companies too, and how we partnered with them with their success and how they've also been able to use the health information exchange as a foundation to support various different public health initiatives too. MyHIN is the first name that I have brought up there too. So we're going to talk a little bit about them, the Michigan Health Information Network. But being one of our early partners, they have grown tremendously, where they are not only the Michigan Health Information Network, but actually now also have expanded. If you've seen the name Velatura, again, a customer of ours, but we've helped them to grow into this new offering where they're also platforming other health information exchanges and doing some really, really interesting and strategic work too in social determinants of health. And we'll talk a little bit about that as well. Then, of course, we'll hit on the New York State Department of Health. And Healthy Connections is one of their regional health information exchanges as well that we work with. So they all are interconnected in some ways, but we'll go into that in just a little bit. So in starting out, understanding how we partner with these different organizations to improve healthcare, it's first and foremost important to understand that we believe that the foundational key component of a health information exchange being successful is being trusted. And we all know that there's challenges in gaining trust from providers. There's challenges with patients, feeling confident that their information is being shared in a way that is going to be beneficial. So really that foundational focus is where we start working with companies too and providing them the tools to quickly achieve high trust certification. So you all are probably familiar with the recent proposal to TEFCA to actually make qualified entities become high trust certified. Typically that's a lengthy process, but through our offering, which I'll talk about in just a little bit, we help to expedite that process with our customers. Now that's not the only thing we do, so we'll talk about that too, but just wanted to help everyone understand that we do focus on the infrastructure and cloud services being secure, compliant, and cost effective. By being able to free up organizations' focus, they can then actually work on the really meaningful work in healthcare and improving outcomes. So the way that we're able to accomplish that quick compliance and security posture is by deploying our proprietary product. It's called Oxygen. Oxygen is a platform that is continuously monitoring, alerting, and remediating various different configuration problems that are common in working in the cloud. Now, those types of challenges that we see often are what have created a sort of a slow adoption of cloud services in the healthcare industry specifically, which we now all have seen, again, during COVID, the benefits of cloud, how we are able to scale quickly in businesses, we're able to quickly deploy and of course have cost-effective solutions. So we'll talk a little bit more about the benefit of cloud, but really this is our focus in making sure that organizations understand that their infrastructure is secure and compliant and can allow them then to focus on the more important topics. Now back to that Mihin Velatura topic earlier that I mentioned. So just to help you all understand kind of where we sit in the world of working with the cloud. And again, we're talking here in this example of AWS. Our practice also works with other public cloud entities too. So just to mention that if anyone is curious. But in the case of Mihin and Velatura, they are built in AWS. Then Cloudticity is their managed services provider. So we are, again, deploying that Oxygen tool in their AWS accounts, keeping them secure and compliant. And then they also work with our team of architects and engineers, where we're able to do that hands-on configuration for them as well. So not just managing their servers, but also deploying code for them and working really closely with them on strategic initiatives. So as they had started out as Mihin, you all see over here, they've grown exponentially. And so you all can see here too, that now they're also hosting other states underneath them, including New Jersey, Georgia, Wisconsin, and so on, and continuously growing. Now, this framework is what has allowed them to really begin to innovate and think about other ways besides just the point-to-point traditional mechanism that we would see in health information exchanges. So one of the more exciting recent announcements that they had was a large social determinants of health initiative where they're actually facilitating a nationwide exchange for referral management. So these types of things have allowed them to quickly innovate, try new things, and have been really successful in growing and scaling. Now, on the road to getting to the cloud, though, working with them, they recognized early on that the reason that being in the cloud was beneficial, it allowed them to be agile and to take on unexpected challenges. As we all know, again, COVID was the prime example of an unexpected challenge. Staying mission focused without falling behind, being able to see cost savings over time, again, with the benefits of the cloud being scalable with your business. Performance, so thinking about things like uptime, and then of course having durability and recovery. So again, when being able to think of the benefits of being in the cloud, being able to go from small and selective, they were also then able to grow to this multi-state or national service quickly with a minimal time investment. It also, by being in the cloud, has allowed them to spin up resources, experiment, try new things, or if they decide that this experiment didn't work, that's okay too. They're not locked into it forever. They can scale or they can shut it down without all of the traditional problems with having to buy new servers or dealing with the hardware investments. Then additionally too, knowing that they have security, confidence, as I mentioned before, and trust in the system. So not only the security certifications and controls that they can leverage from using AWS cloud services, but also the combined services that Cloudticity offers as well. So I'm going to pause there really quick. Any questions at all about working with an HIE so far? And trust me, I promise we're getting to the COVID part itself. But I want to talk a little bit briefly too about some of the challenges in HIEs and interoperability that we encounter often as well. Everyone's doing okay so far? No one fell asleep? All right. So another customer I'd like to share with you of ours too really focuses on the data quality. Now they are our customer, but they are also our partner. And we see this a lot in different organizations that are needing to not just facilitate health information exchanges, but also want to be able to use their data in a meaningful way. And the number one question that comes up is, what do we do about data quality? So anyone that I know, Timmy, you're very intimately aware of the problem of data quality. But we oftentimes have to have that challenge in healthcare of the data that I'm receiving to analyze, it's only as good as what's coming out of the system beforehand. So data quality is a huge concern. So our partner Diameter Health focuses on exactly solving for that challenge. So they're able to use their platform to increase volumes of healthcare data and upcycle it to improve the different quality metrics within data itself. So they call this upcycling data. So knowing that they understand that leveraging inaccurate or incomplete data results in poor outcomes. So their focus is on improving data quality. And here's some examples again too of how that supports in public health use cases. So the Diameter is actually consuming this data, analyzing it using AI tools, and again, all built in AWS and managed by Cloudticity, and then are able to apply that more refined, higher quality data for these different use cases, such as public health or population health initiatives as well. So this has really also been a key component in success with health information exchanges and public health entities that we work with too, is being able to use that data then to improve health outcomes and accelerate the time to the insights, because again, having that nice upcycled data helps really to also reduce costs and redeploy people and enhance workflows. Now, Diameter Health also has another product too that, again, in the HIE is a very interesting offering that makes a ton of sense, but their other focus is on linking together longitudinal patient records. So if we're talking about chronic disease management, for example, we know we might have a patient with hundreds of hospital visits that can sometimes cloud our view of this chronic disease and the state of their disease. So Diameter Health is actually able to stitch all of those different CCD records, or the continuity of care documents, together into one longitudinal record. So in partnership with Diameter Health, we understand the value, and of course we understand the security and compliance of their products as we maintain that too, and work with them to really help to accelerate this public health initiative too, using data in a meaningful way. So when we're thinking about the HIE support for public health, there are so many use cases. And again, I know that traditionally, as I mentioned, we had thought about HIEs as just being that point-to-point transfer. I have provider A that needs information from provider B, and we're facilitating that direct transmission of one single patient's information. While that is incredibly important at the patient level, we all know that public health is looking more at a macro level. So being able to analyze large data sets and to be able to deploy advanced cloud computing solutions can help us to quickly gain insights into various difficult situations that we're facing in public health. So thinking about some of those use cases, again, as we all saw with COVID, of course, needing to have a way to quickly analyze some of the disease patterns within epidemiology, being able to do infectious disease or contact tracing. Also looking at things like capacity planning. So if we're at the state level and we're needing to identify how many ICU beds do we have, do we need to actually go into initiate a plan for FEMA support perhaps? These are the types of challenges that every state is considering now, after we've had to live through the hardships of COVID, of course. But having these systems in place with interoperability at the core fundamental component can allow us to have different tooling and visualization to quickly adapt and solve for these problems. Now, there's other valuable clinical insights as well. So being able to then have robust data sets that can give us patient trend information. So again, in the context of COVID, it's pretty easy that we've all heard of the data use cases, but we all became quickly and acutely aware of some of those contributing factors that were landing patients in the hospital. So being able to identify what comorbidities do make a specific population more vulnerable to a disease state, being able to also track trends of how are we doing with the efficacy of our care? Are our patient outcomes improving? The length of stay is reduced. And again, of course, as we think a little farther out too, what is our total cost of care, which is a completely different conversation. But again, the cloud allows you to scale in that way too, of how can we bring in not just patient care data, but also thinking about the iron triangle, which is our quality, our patient care, and then any of the cost of that as well. In chronic disease management, again, too, I alluded to that one earlier as well. Having the visibility too, where we can start to see, trends in patients and even predictive trends for chronic disease management too. So shifting more towards that value-based care, doing the types of outreach that are proactive versus being reactive. And again, all can be supported by facilitating different cloud native tools. Now, in the case of the state of New York Department of Health, I know this is a big buildup to get to the COVID discussion. The state of New York, it's important to understand the way that their organizations are structured. So at the base, there is a statewide health information network for New York. It's called Shiny. They have 6 different regional health information organizations, or they call them qualified entities, of course, QEs, which enable that sharing of data statewide, ensuring that they provide the access to the electronic medical records wherever and whenever they need. Now, earlier as well, in this work closely as well with Healthy Connections and have great relationship.
Is Amber going out or am I?
No,
Yeah.
poor Amber's
Yeah,
gonna-
she's cutting in and out.
Okay, Jerry, can you step in?
Yeah, for sure. And then Amber, you're cutting in and out, but if you come back in, feel free to take it back. So the work, to step back just a little bit from what Amber talked about, the work that we did with the state of New York, it started in March of 2020. They called us on March 23rd. I know because that was my birthday. And at the time, if you remember, New York State was the hardest hit state in the country with COVID. We all recall the refrigerator morgues on the street and that sort of thing. And so when they called, they said, how many months will it take to build a data lake so that we can begin attacking this problem? And based on, because of the flexibility of cloud, we were actually to get that up and running in 6 days. And 6 weeks later, New York State went from being the hardest hit state in the country with COVID to the first state to cross green. And being able to aggregate data from all 6 QEs. Amber, are you back?
I'm back.
Okay, I'll turn it back to you. I was just giving sort of the background about New York State and how quickly the cloud allowed us to get that operational data lake in place, and some of the things that they were able to do as they had that open source aggregate data set that they could start leveraging for analytics and for contact tracing.
Yeah, absolutely. So as Jerry was filling you all in, and sorry about that technical problem there, but the state was receiving numerous CSVs and they were feeling overwhelmed and needed a more sustainable solution that could also scale with them as well with that clinical data. And again, scalability, I can't say that enough with COVID, as we all saw the peaks and valleys of influx of data as well. So they wanted more automation so they could effectively drive their response activities. So we deployed a Cloudticity product called Data Hub, which uses all native AWS services. And then we're able to have them processing data within 5 minutes of delivery, which gave them insights on real-time data of comorbidities, the length of stay, symptoms, again, looking at capacity swells as well, performing that contact tracing and controlling spread. And now, of course, we've been seeing that trend in a good direction now. So that's all been positive in helping them not just be able to say we know that we have a problem, but actually quantify exactly what is happening with the whole public health initiative. All right.
Amber, with the New York use case, which I think is just incredibly compelling that you were able to help the state directly, are they still using it? Was it kind of a point in time, or what is the, what's the update now?
Yeah, actually great timing. I just chatted with them this morning. They do still use the tool. So they are still getting that information that comes in for them to still see what COVID hospitalizations are like. And again, all of the data around that. They actually have been working to add in even more robust data sets. So they're continuously evaluating other use cases. And For the state specifically, their focus has to shift for a different disease process too, just like every public health entity. So now having this foundation in place can also allow them to use this in other data use cases as well. So this was built specifically with the use case of COVID, but again, might be thought about for other types of illnesses that we may need to be tracking. So historically, again, before we all knew the word COVID-19, we also were always tracking, at a state level, the number of influenza hospitalizations. This is exactly a tool that could be easily pointed towards tracking those types of hospitalizations. And actually, I chatted with them this morning too around some of the new CDC funding that just actually came out to states regarding preventative care as well. So how do we then consider being able to bring in this information on patients that are in need of cancer screening? So we know that there are specific, high priority cancer screenings for preventative care. How do we proactively engage those patients or identify the ones that maybe there's a specific common thread of the patients that aren't seeking preventative care services? And again, we can create a strategy around that too. So this, again, their initial use case was COVID, but we're continuously working with them on other potential problems that they can solve with the same kind of common infrastructure of looking at that hospital admission information, or looking at the HIE information, which is giving, again, the continuity of care documents, and then also they're aggregating in lab data as well. So those components really give you a pretty comprehensive view overall of a patient. It's not necessarily the end all be all of one patient, but from that aggregate level, it can really provide some important insights to population health and where you should be focusing your efforts, in improving the outcomes too. So I think that's one of the key pieces, not just the technical, what is it doing, but then understanding, in public health, when we're creating these plans, we always start with the outcome itself. So we're going to look and say we have a poor outcome. In that case I mentioned to you earlier, the preventative screening. Wow, we see that we have 5 million people in our state that are overdue for having a colorectal cancer screening or a mammogram. That's a problem, because that means we're likely going to have a higher instance of cancer. So we know that that's the problem, that's the outcome. So now we work backwards and say, if we want to improve this outcome, where do we go to work upstream and employ new practices that will overall make an improvement to that patient outcome itself too. So again, technology is the foundation really for that, to be able to enable various different public health initiatives just by having your data consolidated and being able to quickly identify where you are today will help to guide where you need to go in the future, and serving your community and your population as well, because that's been, I know, another challenge, I think, historically. Oh, is there a question?
Yeah, one more. I'm sorry. I just want to interrupt. I did interrupt, but I was wondering, so the compelling piece about New York, and when you translate that to California, is in California, we have regional HIEs and state HIE as well, that crosses many regions, but we don't have one state HIE like the Shiny or the MHIN, one state HIE. So we have multiple HIEs, and there is white space. But did you, when you stood this up, who your client was, the state, did they then contract with Shiny, and then Shiny was able to promulgate contracting and getting the data from the HIEs? Or how did that kind of structure work, the relationships work, to be able to pull something off in 6 days?
Yeah, basically the state executes their authority. That's step one. And that they're able to say, this is a requirement, QEs, this is something you have to be submitting. And so that's the first step of them being really in the driver's seat of saying, this is something that is a requirement for us at the state level. They have this relationship, again, Shiny is working with them collaboratively around, disseminating that information to the qualified entities. But we actually work directly with the QEs too during this implementation, because they also had to be agile and making sure that their systems had the correct data, and being able to make sure that they're submitting correctly for what New York's ultimate goal was. So a lot of the challenge, in working with different organizations like this, there's the technical piece is this much of the problem, as you know. Then
Yeah.
of course, people in process that we have to always work through too. And so the state really ultimately is the driver in that situation, where they are the ones ultimately saying, we recognize that we are the owners of the public health initiative. And because of that, we need you entities to be compliant and support us in what we're trying to do in sharing that data with the Department of Health. So I think that's probably the first key of being able to be successful in getting them to comply with that.
So it was.
I remember being on the initial calls, and there were probably a dozen different agencies, the QEs and Shiny and NICE and New York Department of Health. And there were upwards of 200 people representing those various organizations on these initial calls. And I remember, at first there was a little bit of turf battle, under normal circumstances, this would have been an 18-month project that everybody collaborated and pulled off in 6 days. But remember when we would get into turf battles and we would go down, a squirrel hole on who's going to own what data or what data elements will be sent or not sent. And, after maybe 15 minutes, I would chime in and say, hey guys, how many people died during the time that we just had this conversation? And everybody got on the same page again. So it was driven by extraordinary circumstances that really drove everybody together, because we had a common mission to solve the problem of people dying. And, that the gravity of that really lent itself toward an acceleration and a cooperation. But much of the work, as Amber said, was policy related, not technology related. The tech, to me, was easy. It's the policy of getting so many disparate entities that have their unique perspective, their unique, each QE has contracts with the providers that feed data to them, and they've got to be respectful of that. And but this was the art of the possible. And what I'd like to see is that in the days where we don't have extraordinary circumstances, we look back to this success and realize, look, this can be done. And
Right.
if we can bring policy together under normal circumstances, the net result on humans is tremendous.
That's awesome. So thank you so much. I'm just looking at the chat. Are there some questions?
Yeah, I saw a comment there too about the QEs having their own data vendors on the back end, and that's absolutely correct. They are all each individual organizations. They have their own, first of all, they have their own set of providers that they're serving, which also comes with its own nuance too, right? What are those providers even able to submit to them, and what data they're able to extract from their EMRs? That's the first piece. And then, yeah, to your point, they have their own tech stack. They have their own master patient indexes that we see a lot of times. We're seeing, various integration engines that they're now starting to realize that that was an old archaic way of doing things. And that's really where we've been partnering with them too, is saying, doing these old point-to-point interfaces, they break, they're not secure, they're not reliable, and we work with them to then create more cloud-native solutions.
Jim's asking whether or not your tools are all built on AWS, or do you use other third parties?
We support both AWS and Azure. 100% of what we do at Cloudticity is cloud native. We have our thesis for the company from day one, when we started the company in 2011, was that the cloud is the best tech stack behind healthcare data integration. So all of it is cloud related. We use some third parties around security. We're partnered with Trend Micro to do some security analytics, that sort of thing. But the vast majority of our tech stack is AWS and Azure native.
Yeah, and we do support other institutions bringing their own license as well. So if they have other applications that they're needing to host in their AWS environment, we do that all the time. There's a broad array of different applications that different types of organizations are looking to move from their on-prem to the cloud. And that's absolutely something that we support for them too, and help them to work through the challenges of doing those types of migrations.
Yeah, Timmy, if I could follow up on that, because that wasn't quite there. Yeah, so got all that. I was wondering, are you rolling your own code natively for microservices, or are you building them off of something like TIBCO or Cisco parts and products for the data brokerage architecture?
It's all our own code.
Cool.
Yeah, so we build it. It's I'll geek out for 30 seconds. So don't let your eyes glaze over, but it's AWS API gateway on the front end. It's Lambda code, which is all of our own code, primarily written in Node.js, with a little bit of Java thrown in there. So all of the microservices, all of the magic stuff happens in code that we've written.
Excellent, spot on. Just what I wanted to know, and I'll follow up with you separately, Jerry.
Yeah, absolutely, for sure. Thanks.
Great. And if we could do that, Amber and Jerry, if you want to throw your emails into the chat, I think there will probably be some follow-up. Thank you. I think the art of the possible is what we really wanted to make sure got through loud and clear. So we will also follow up to make sure that we can highlight and promulgate this work and make sure that our state advisors are aware.
Thank you.
Robbie, and thank you. Robbie, I'm going to hand it over to you to introduce Karen.
Great. Thanks, Jerry and Amber, so much. And I guess without further ado, Karen, would love to hand it over to you. You know, I know the coalition, we were really in the deep of analyzing the state's data sharing agreement draft a few weeks ago. I really wanted to highlight your data explainer you helped put together with the California Healthcare Foundation. And I think maybe if you could just start with a brief overview of the work you did with the foundation and what it outlines, I think that'd be super helpful for the coalition.
Yeah, great. Thanks, Robbie. Thanks to me for having me back. Hi, everyone. I am Karen Ostrowski, Vice President of Policy Innovation with Intrepid Ascent. And we were engaged by the foundation to put together a series of explainer documents on some of the key topics that relate to the data exchange framework. And yes, to me, you're right. It's the last, we've had 4. The last of the series was published last week on digital identities. And yeah, great. Thank you, Robbie, for throwing that up there. So yeah, all 4 papers have been published. We talked about in some of the other ones, besides digital identities, we also covered topics related to potential incentives or levers that the state could use to encourage or even mandate participation in the data exchange framework, and then also on governance structures that might be considered for overseeing and managing the data exchange framework. So this, the other paper was on data sharing agreements. That's one I'm gonna just talk about really briefly today and see if there's anybody has questions or reactions in the context of, you know, the most recent developments. And I would say we really, you know, wanted to, you know, while these were all of the papers were intended to kind of stand alone and kind of help inform the conversation going forward, we really did try to also, you know, kind of in real time develop some of the content based on the rapidly evolving conversation at the advisory group and just all of the other subcommittees. So, you know, some got into some of the work that was done, but I think, as I said, you know, largely we wanted all of these papers to be things that can continue to shape the conversation. So, excuse me, this, so the explainer on, excuse me, bad timing for it to go. This paper really focused on, you know, we started with outlining some of the key elements of data sharing agreements, certainly not exhaustive, but we highlighted the 5 most common and, you know, what I think are some of the most critical elements of provisions of data sharing agreements, things like purpose and scope, permitted uses and disclosures, and privacy and security safeguards. And then what we did is kind of lay out considerations of those same elements in the context of AB 133 and what it says for the statewide data sharing agreement. And then, excuse me, the third component was talking about how those elements are at play in other data sharing agreements that we are all commonly familiar with. So like the TEFCA Common Agreement, Carry Quality, C10, and the CalDERSA, and just to kind of lay out pros and cons or considerations of how those agreements and what their provisions say may or may not be helpful or relevant for the state's data sharing agreement. And I really want to just, like I said, mostly leave time for questions or reactions, but I will just highlight, one of the things that stood out as we were putting this together was that none of the existing agreements really are sufficient on their own. And I think, we saw that play out with the actual draft of the data sharing agreement. But if you've even, listened in one of the advisory group calls, that the conversation and many of the stakeholders continue to say, why don't we just follow TEFCA? Or, why are we trying to do something different? And I think, one of the main takeaways from this paper, at least from my own personal perspective, was that, we can't just take TEFCA and adopt everything because it's not sufficient to meeting the goals of the data exchange framework and the vision that the state has. So that's, I think one of the biggest takeaways, at least, like I said, for me. But I guess I'll just pause and see if anybody has questions or reactions about this particular paper. Yeah, exactly, Jim. Yeah, TEFCA has shortcomings, and as I said, and I think a lot of us recognize that it just is not going to be sufficient for the broad goals that the state is trying to accomplish around social determinants of health and, really expanding the data sharing ecosystem and incorporating, other sectors and community-based organizations and really, being an expansive and kind of going beyond a clinical or kind of traditional HIE focus.
Yeah, and I haven't had a chance to read your papers. I'm looking forward to them, but I know just with the topics we've discussed here, and I'll be upfront that Avenir is running into some problems with TEFCA and QHIN because TEFCA specifies that you have to use the portfolio of IHE services. And if you propose something really new and really novel in a technical approach, basically ONC and Sequoia are saying, nope, you gotta follow this box of 1982 Camry parts, even if you re-engineered a hybrid Ferrari, and that's causing real problems. So
yeah.
Karen, I have a quick question in terms of just where we are today with the draft data sharing agreement. I mean, it's getting pushed pretty quickly. Next week, we have the data sharing advisory group that I think is going to be adopting the data sharing agreement. What is your sense of current state? If you were to write the paper right now.
I just, I continue to be struck by just how many details are still TBD. There's just so many things that is not clear. I think, a lot of folks, if you saw a lot of the initial public comment and reactions by the advisory group, a big part that has been left out or has kind of been pushed to the future is the concept of the qualified HIO. And, what does that mean? What are the qualifications? How will the state determine who meets that? And, what I guess also some of the implications for, because the state has said, doesn't matter how you exchange, just exchange. And there are a number of avenues. But I think there are so many questions there about what does that mean if you're on Epic or you are connected to Carry Quality, and how do we resolve some of those things? So I think for me, my biggest takeaway is just that it's so confusing and there's still so many questions that it's hard to even think that organizations are going to be able to have a meaningful deliberations at their organizations over the next few months in preparation for needing to execute it in January. So I just, that for me is my biggest hang up at this point.
I was going to, I think, piggyback off of Timmy's question. And I think one thing that was really brought up in coalition meetings here is kind of the lack of acknowledgement of like social care and services organizations and their needs. Obviously it's much harder because there's a different or non-existent, compliance structure when it comes to privacy and security in a lot of cases, or data standards. But what's your sense of, how the draft has sort of treated social care organizations, and what's your take on maybe what's needed to really improve the data sharing agreement, so that even though those organizations may not be mandated to sign the agreement, it could be palatable to them, or doable?
Yeah, I think in some cases, like for example, the application of HIPAA standards, I think the deliberation around that has been really good, and what standards to hold non-covered entities like social services and CBOs, what is reasonable. I mean, they're obviously not otherwise bound by HIPAA, in a majority, but at the same time, we need some sort of a baseline. So I think, they've done well, but I think there's still, again, not as much consideration that is probably needed. And I think it's probably why the state has not pushed for those organizations to be kind of in the early group, is to give more time for readiness and outreach and technical assistance. So I think it's been okay, but I think there are still a lot of questions.
Definitely. That's my sense too.
And I think that's something that we're looking at for next week, is what is the governance structure going forward? And from everything's pointing to that this advisory group and the work group around the DSA is going to be disbanded.
Right. It's gonna be the statute is gonna have to outline I've seen in other cases where the statute, the implementing statute, grants authority and defines those advisory groups, just like we saw in AB 133. So I think that's a big, kind of next step, is what are we going to see in statute that outlines some of this? Because without having some of those governance activities spelled out in statute, as we've talked about before, it's hard for the state or others to have any kind of authority.
So maybe that's something that as a group we focus on in the next few weeks, is what would that statute look like, and can it get into the trailer bill now in this legislative session, or instead of waiting until the January legislative session, or else can we keep our foot on the gas? I don't know.
Yeah, exactly.
Any others kind of thinking about that at this point? It's been definitely something that I've been really concerned about. Not many folks are turning their cameras on.
Okay.
All right, I'll hand it back. Robbie, any other questions for Karen?
No, I don't think so. I think, thank you for all your work and the data explainer and the analysis you've been doing in review. I think it's been super helpful for our purposes in figuring out how to analyze the data sharing agreement and, structure our comments and such. So thank you so much for all your work, and come back and present on your next publication. We'd love to have you.
Absolutely. Yes. Thank you so much.
Excellent. So I think next up, we just wanted to go over our comments that were submitted to Cal HHS on the draft strategies for digital identities. And I think big thanks to all of you, many of you on this call who submitted really, really helpful feedback to Timmy and myself. I think really to put some context to this, AB 133 also called on Cal HHS to not come up just with a framework or a data sharing agreement, but also a strategy for digital identities, kind of defining what that is and laying out a roadmap for the state. Additionally, here are the comments as we kind of structured them and laid them out. We kind of tried to follow largely the structure of the strategy document itself, but to kind of highlight a few around stakeholders represented in the focus groups that the state held and who opined, we recommended they list who those folks were and the sectors they represented. I think one of the pieces of feedback is that there really was an underrepresentation of social care providers, like direct service providers, not necessarily even just state agencies or folks who may handle referrals, but really the direct service providers themselves. Also to kind of delineate and further flesh out a lot of the definition of terms used. So patient matching versus person matching versus record linking, really to kind of disaggregate what the state means by those terms and also make sure that they're kind of distinguished from each other. Also to just around, the idea of creating a statewide index, really to look into what kind of proven or already deployed approaches could be leveraged in this work. So thanks for that input from you all. Just, look at what is care quality doing versus Commonwealth. What can we learn from those examples? Additionally, public-private participation, really calling on Cal HHS to also include how we can consider what state agencies are already doing around patient matching and the like. So the all payer claims database, cures, for our prescription drug monitoring program, the forthcoming Pulse registry, how are they all thinking about patient matching and how can Cal HHS make sure that it aligns with what the rest of the state and their agencies or programs are doing. Additionally, I think, again, calling out, gaps in social care services data standards. There's a lot of mention of health data standards like USCDI and the like, but really just, calling out and giving some acknowledgement to the inclusion of social care and, what may be needed to make this statewide person index also work for those organizations too. Additionally, thanks for some of the other feedback that was provided by you all, around methods of privatization, really calling on Cal HHS to kind of build out that section too, as well as some of the other strategies that have been deployed around patient identity. So the Pan-Canadian Trust Framework and the EU EID wallets, thanks for those suggestions, Jim. And I think last but not least, reminding the state we need funding and we need governance to make this work. So not just for the data sharing agreement to work or the other pieces of the framework, but also for a statewide person index to become reality. The state needs money to do that, not just for its own purposes, but also for the organizations that the state anticipates will participate in this work. I'll pause there to see if folks have any feedback or thoughts. Anything else you may have included in comments you submitted?
Thank you for all of those of you who shared your comments with us too. And we are also tracking those that are posted up on the CHHS, the framework website, and continue to monitor it. I think ours are up there, right?
They are, yeah, they've posted all the comments. There were fewer comment letters compared to the data sharing agreement, but there still were several submitted, and I know several of you on this call are included in that list.
And Robbie and I are reaching out to John Ohanian to have a discussion and make sure that we address any questions that they might have. So we'll keep you posted on that.
Excellent. I guess just as a reminder, as Timmy mentioned, next week is the last big stakeholder advisory group meeting on the 23rd. They'll be reviewing updates to all of these documents that they've shared and based on the public comment they've received. So I think we'll get a good sense next week of what the final documents will look like ahead of the July 1st deadline for finalizing them. And additionally, just another, policy update for folks. Yesterday was June 15th. The deadline for passing a budget in the state. The governor did sign quite a large budget, over $300 billion. And more work will come through trailer bills to kind of further define a lot of the policy related to a lot of the appropriations in that bill. Just to call out a couple things for folks, the proposal we've been tracking all year that the Equity Coalition proposed for Medi-Cal performance payments and HIE infrastructure was not included in the budget. It had been taken, it wasn't in the May revised proposed by the governor or put back in by the legislature. Additionally, the equity and practice transformation grants that Medi-Cal had proposed and the governor supported were also stripped. And those would have included purposes for those grants to include, HIT and HIE improvements. There was an appropriation made for the EMS agency for a planning process to improve interoperability between EMS providers and receiving hospitals via health information organizations. So that's in there. There also was some funding for PACE programs to update their health IT systems, as well as some money too for community health centers to improve their data sharing with public health agencies as well. But I think nothing kind of along the lines of what had been proposed in terms of kind of a robust budget package that included drawing down federal funds for things like incentive payments and like. Felix, you have your hand up. Anything you'd like to add? I think Felix may be frozen.
Oh, no.
But
The Zoom gods are getting us today.
I guess I'll just say, I think it's unfortunate that, there wasn't more funding put towards HIE or interoperability in the budget, especially given that the data exchange framework is being finalized shortly. But definitely is opportunity in the next session, to try to push the state for more funds. And, we may see further policy come through in some of the budget trailer bills. So there's still opportunity to, make some inroads in policy this session. So
I think as we've done in our letter so far of really pushing now around the allocations, the budget allocations for large programs, including CalAIM and the population health management the tool for Medi-Cal, like what can be the carve out to be able to support HIE? I think we really need to focus on that because there is ample funds to be able to support data exchange.
Hey, Timmy and Robbie, sorry.
Hi, Felix.
Popping in and off, but that was a really helpful overview there, Robbie. A slight but important clarification is that the governor has not signed this budget bill the legislature passed, SB 154. This is the legislature's placeholder budget, as your previous slide indicated. Negotiations are still very much live and ongoing. There's actually a couple of major items of difference between the governor's priorities and the legislature, and we don't expect them to be resolved probably until the very end of the process, right up until bumping against July 1st. That being said, like you're very apt to point out that our request for funds for health information incentives and infrastructure was not included in either the legislature's version or the governor's original proposal, and we don't expect at this point any major changes on that front. But we, the coalition that have advocated for these funds, are still looking for avenues to at least try to set the stage for a more successful effort next year. So stay tuned, and we'll let you know if anything exciting or promising breaks in that direction.
Awesome. Thanks, Felix. And I guess just to highlight a couple news items for folks too before we wrap. SB 1033 is one of the is a bill that the coalition supported around health plans collecting demographic and SDOH data. That'll be heard next week in Assembly Health. A recent op-ed came out from the Inland Empire Health Plan CEO, really calling on the state to invest in health information exchange. There's also a competition that USHHS has launched around promoting innovation in primary care. Our friends at Blue Shield of California Industry Initiatives will be having an in-person event in Oakland on, July 13th, not June. That's all to say too, if you have events you'd like to share, please send them our way. Additionally, a recent MedPAC report really has highlighted some gaps in health IT adoption for behavioral health practices. And last but not least, the California Healthcare Foundation published a recent health IT landscape that's pretty comprehensive and recommend you all check out. Anything you'd like to add?
No, I just would love, I really am looking forward to the event. It's in Oakland and I think it is, mark your calendars, it's on July 13th, correct? And we'd love to be able to meet in person. And we've been looking forward to a way to do that. So please, let's meet up and can't wait for it. And then next in our, I want to go quickly to our calendar. I'm really excited about our next speaker, which is in 2 weeks. There we go. And this is, I don't know if you all remember, but probably like 6 months or so, we were alerted about mental health services has an EHR that they are rolling out, and we're going to learn about it in 2 weeks. So it's just really, it's cool that they're going to have a broad EHR that can be used by our behavioral health providers in the state. So really looking forward to that. And Robbie, anything else?
Nope.
Okay. Well, thank you, everyone. Enjoy midsummer. I guess the kickoff to summer. We'll see you in 2 weeks. And I think we'll see everyone at the Data Exchange Framework Advisory Group next week too. So let's all tune in. All right. Thanks.
Thanks, everyone.
Thanks, everybody.